Welcome to the Deep Dive. Today we're tackling malaria. It's a really serious infectious disease caused by parasites, transmitted through Anopheles mosquito bites. And it's kind of a stark reality that even though it's preventable and treatable, it's still this, massive global health challenge.
Yeah, absolutely. And for this session, we're looking at a pretty comprehensive report. It gives a really detailed view of malaria, everything from the basic biology right up to the global efforts trying to eradicate it.
Exactly. So our mission here is to pull out the most critical stuff from this report. The history, where it came from, the symptoms, how we diagnose it, treat it, and maybe most importantly, how we prevent it.
Right.
We really want to get a handle on why a disease we know how to fight still causes so much illness, so much death across the globe. And here's something to really focus on. In 2023, nearly half the world's population was at risk, almost half. And in that same year, something like 94% of cases and 95% of deaths were in sub-Saharan Africa.
It's just staggering numbers.
It really is. Okay, let's really get into this.
Okay, so malaria, fundamentally, it's an infectious disease caused by these tiny single-celled parasites, the Plasmodium genus.
Right.
And they get passed between humans by female Anopheles mosquitoes. Basically, an infected mosquito bites someone, injects the parasites, and that kicks off this really quite complex life cycle inside the human body.
And that's the thing that really grabs you, isn't it? Preventable, treatable, yet this huge global impact. Why? What's the gap there?
Well, it's complicated. It really points to systemic issues. It's not just about the parasite or the mosquito. It's really fundamentally about access.
Access to what specifically?
Access to, everything needed to fight it. Can people get tested easily and accurately? Can they get the right medicine when they need it? Are things like insecticide-treated bed nets actually available and used consistently? And then beyond that, you have to look at the bigger picture. How strong is the healthcare infrastructure? Are there enough resources, money, trained staff? And then the broader socioeconomic stuff like poverty, education levels, it all feeds into this gap.
So it's a whole system failure in a way.
In many ways, yes.
So when we look at the actual numbers, what's the current global picture? What are we talking about?
Okay, so the latest figures. In 2022, there were roughly 249 million cases globally. That led to about 608,000 deaths across 85 countries.
Wow.
And then in 2023, unfortunately, cases ticked up slightly, maybe to around 263 million. Deaths came down a little, thankfully, to about 597,000. But the concentration, it's still overwhelming. 94% of cases, 95% of deaths in 2023, all in sub-Saharan Africa.
That concentration is just hard to fathom. And it's the youngest who suffer most, right?
Absolutely. Children under 5, they are incredibly vulnerable. In Africa in 2023, they accounted for something like 76% of all malaria deaths.
76%.
Yeah. And globally, that figure is around 80%. Pregnant women, too, they face a much higher risk.
It's devastating. And it makes you ask, why? Why is it so heavily concentrated there in sub-Saharan Africa? It can't just be mosquitoes, surely.
No, it's definitely not just the mosquitoes, though they're obviously key. It's this really deep, complex mix of things. Environmental conditions matter. Yeah, they affect mosquito numbers.
Right.
But then you have huge socioeconomic challenges, poverty, sanitation issues, the kind of housing people live in, that all increases exposure. And then you layer on the public health system challenges. How strong are the services? How far do they reach? Is there good education about prevention? Even cultural factors can play a role in how effective things like bed nets are.
So tackling it needs really tailored solutions.
Exactly. Solutions that fit the local context, that are culturally sensitive, and importantly, that are part of broader development efforts. It's not just a health issue in isolation.
Okay. Let's switch gears a bit. Let's look back. The history of malaria. You mentioned it's ancient. How far back are we talking?
Oh, way back. We find descriptions that sound very much like malaria in ancient Chinese texts, maybe around 2700 BC.
Wow.
Mesopotamian tablets from 2000 BC, Egyptian papyrus 1570 BC, Hindu writings from the 6th century BC. It's been with us a long time.
Millennia. So people back then, they noticed these patterns. Fevers, sickness, near swamps.
They definitely did. Ancient Greeks, like Homer, around 850 BC, Hippocrates around 400 BC. They wrote about these recurring fevers, people having enlarged spleens, and they linked it to living near marshes, near stagnant water. They saw the connection, even if they didn't understand the cause.
Right. And for centuries, the big explanation was this miasma idea.
Yeah.
Bad air.
Yes, exactly. For well over 2,500 years, the dominant belief was this bad air, malaria in Italian. Plasmodium, which is likely where the name came from, rising from swamps, was the culprit. That idea really stuck.
Amazing. So when did the science finally catch up? When did we figure out it wasn't bad air?
The real breakthroughs started happening in the late 19th century. 1880, a huge moment. Charles Louis-Alphonse Leveron actually saw the parasite in human blood.
He saw the parasite itself.
Yep. Then, 1897 was a big year. William McCallum found the sexual stage of the parasite in blood, another key piece. And the same year, Ronald Ross worked out the whole transmission cycle in mosquitoes, finally linked the insects definitively.
That must have been completely revolutionary, the mosquito link.
Oh, absolutely. And just a year later, 1898, a group of Italian researchers, Grassi, Bignami, and others, showed specifically that Anopheles mosquitoes transmit human malaria. That really cemented the understanding.
But even then, the story wasn't quite complete, was it? There was more to learn about the parasite's life inside us.
Correct. It kept evolving. In 1948, Short and Garnham discovered the liver stage, that the parasite goes there before hitting the bloodstream. That was crucial.
The liver stage?
And then much later, in 1982, Wojciech-Krotowski finally nailed down the existence of those dormant liver stages, the hypnozoites. That explained the relapses you see with some types of malaria, like Vivax.
It's credible tracing that path from just observing fevers near swamps to understanding these tiny details like dormant liver stages.
It really is. It shows how persistent malaria has been as a challenge, but also, the power of science to slowly unravel these incredibly complex biological puzzles.
And it highlights how the parasite and mosquito keep adapting too, right? Always presenting new challenges.
That's a really key point. Even as we understand more, the biology keeps throwing curveballs. It means we constantly need new research, new strategies.
Okay, so we know it's a Plasmodium parasite carried by Anopheles mosquitoes. Let's dig into the specifics of that. The causes, the transmission.
Right. So it's caused by these protozoan parasites, genus Plasmodium. 5 species infect humans, but the 2 big ones, the major threats globally, are Plasmodium falciparum and Plasmodium vivax.
And the others?
The others are P. ovale, P. malariae, and P. knowlesi. They can cause illness too, but falciparum and vivax account for most of the burden. Falciparum is especially dangerous because it's the one most likely to progress to severe, potentially fatal malaria.
And vivax and ovale.
Yeah.
They're the ones with the dormant stages, the hypnozoites.
Exactly. That's their unique and problematic feature. They can hide out in the liver, dormant, for weeks, months, even years sometimes.
Wow, years.
Yeah. And then they can reactivate, causing a relapse long after you thought you were cured.
That must make treatment much more complicated for those types.
It absolutely does. You need drugs to kill the parasites in the blood, obviously. But for Vivax and ovale, you also need a drug like Primakine, specifically to target those dormant liver stages to prevent the relapses.
Okay. Now, the mosquitoes, Anopheles, it's not just any mosquito, right?
That's right. Only female Anopheles mosquitoes transmit malaria to humans. And even within the Anopheles genus, there are, I think, around 460 species, but only a relatively small number are actually efficient vectors for human malaria.
So what makes a particular species a good, or I guess a dangerous vector?
Several things. They need to be abundant, obviously. They need to live long enough for the parasite to actually develop inside them. Crucially, they have to bite humans frequently, often preferring humans over other animals, and they tend to live near where people live. It's all about maximizing the chances for that parasite transmission cycle.
Makes sense. Proximity and preference. And the environment must be a huge factor, too, for the mosquitoes themselves.
Oh, absolutely huge. Transmission intensity really depends on environmental conditions. Things like temperature, rainfall patterns, humidity. They all affect mosquito breeding in water sources and how long the adult mosquitoes survive.
Right.
And human behavior is key, too. Where people live, how houses are built, whether people use preventative measures like nets, it all affects how much contact there is between humans and these vectors.
Okay, let's trace the parasite's journey, this 2-host life cycle. Start with the human side, the mosquito bites. Then what?
Okay. So an infected female Anopheles bites, and she injects sporozoites, that's a specific stage of the parasite, into your bloodstream.
Sporozoites, got it.
These sporozoites travel pretty fast to the liver. They invade liver cells, and then they start to mature and multiply inside those cells, forming something called a schizont.
And they just multiply inside the liver cell?
Yeah, they reproduce asexually, making lots and lots of copies. After maybe a week or two, depending on the species, these schizonts burst open, releasing thousands of new parasites called merozoites into the bloodstream.
Oh, okay. So that's when they get into the blood.
Exactly. And these merozoites then invade red blood cells. Inside the red blood cells, they multiply asexually again. And it's this stage, the multiplication within red blood cells, that actually causes the symptoms of malaria.
So the fever, the chills, feeling awful, that's because of the parasites bursting out of red blood cells.
Precisely. As they multiply, they rupture the red blood cells, releasing more merozoites to infect more red blood cells. This cycle causes the classic symptoms, often in waves. Now, interestingly, some of the parasites inside the red blood cells don't just keep multiplying. They develop into sexual forms called gametocytes, male and female ones.
Okay, and why do they do that?
They don't cause illness in the human, but they're essential for the next stage transmission back to a mosquito. And remember, with Vivax and Oval, some of those initial sporozoites in the liver don't develop right away. They become those dormant hypnozoites we talked about, just waiting.
Waiting to cause trouble later.
Right.
Okay, so now a mosquito comes along and bites someone who has these gametocytes in their blood. What happens inside the mosquito?
Okay, so the mosquito takes a blood meal and ingests these male and female gametocytes. Inside the mosquito's gut, sexual reproduction happens. The male fertilizes the female, forming a zygote.
Right.
This zygote develops into a motile stage called an ookinet, which burrows through the mosquito's gut lining and forms an oocyst on the outside wall of the gut.
So it forms a little cyst on the gut wall.
Exactly. And inside that oocyst, the parasite multiplies massively again, asexually, producing thousands and thousands of sporozoites.
The same stage that started the human infection.
Precisely. When the oocyst matures and bursts, these sporozoites are released into the mosquito's body cavity. They then migrate to the mosquito's salivary glands. And now that mosquito is infected and ready to transmit the parasite to the next person it bites. Cycle complete.
It really is an intricate dance between two hosts. Amazing biology. And understanding all those steps must be absolutely vital for finding ways to stop it.
Absolutely critical. Every single stage in the human or in the mosquito is a potential target for intervention, whether it's drugs that kill parasites in the liver or in the blood, or vector control methods that kill mosquitoes or stop them biting. Targeting these vulnerable points is key to breaking that chain of transmission.
Okay, so someone gets infected. We know the cycle. What are the first things they might feel, the initial symptoms?
Well, in someone who doesn't have much immunity, the first symptoms of uncomplicated malaria usually show up maybe 10 to 15 days after the infected mosquito bite.
Okay.
But the tricky thing is, early on, the symptoms can be really vague, very nonspecific, easily mistaken for, say, the flu or another common illness.
So what kind of things? Like a fever?
Fever is the most common, yeah. Often comes with chills, headache, maybe sweating, feeling really tired, nauseous. Sometimes vomiting or diarrhea, body aches, just generally feeling malaise.
Right.
And if a doctor examines them, they might find a fever, maybe an enlarged spleen, sometimes mild jaundice, a yellowing of the skin or eyes, maybe an enlarged liver.
It really does sound like the flu. So diagnosis could easily be missed, especially if you're somewhere malaria isn't common.
That's a huge challenge, especially in non-endemic areas. Healthcare providers might just not think of malaria first. And any delay in diagnosis means a higher risk of it becoming severe, particularly with falciparum.
Right.
On the flip side, in places where it is common, people might just assume it's malaria and self-treat without getting tested, which causes other problems, like contributing to drug resistance. It really underscores why good, accessible diagnostic tests are so important.
And if it's not treated quickly, or if it's falciparum, what happens then? What does severe malaria look like?
If it's left untreated, a falciparum malaria especially can get very bad, very fast, sometimes within 24 hours. We're talking severe complications like severe anemia because so many red blood cells are destroyed.
Okay.
Breathing difficulties, cerebral malaria, that's when parasites affect the brain, leading to coma, seizures. Jaundice can become severe. Kidney failure, multiple organs starting to fail. Fluid in the lungs, pulmonary edema. Dangerously low blood sugar, hypoglycemia, problems with blood clotting like DIC, abnormal bleeding. It's a whole cascade of potentially fatal events.
That sounds absolutely terrifying. Are the severe effects different between, say, kids and adults?
There are some tendencies, yeah. In young children, severe anemia, breathing problems linked to metabolic acidosis, and cerebral malaria are really common and major killers. In adults, you can see those too, but perhaps multi-organ failure is seen a bit more frequently. And it's crucial to remember, even if someone survives cerebral malaria, especially a child, they can be left with long-term neurological problems.
Right, the damage can persist. What about the incubation period? You said 10, 15 days typically, but it can vary.
Yeah, the usual range is about 7 to 30 days between the bite and the first symptoms. But remember Vivax and Ovel with their dormant liver stages?
The hypnozoites, right.
Because of those, the incubation period can be much, much longer. Symptoms might not pop up for several months or possibly even a year or more after the initial infection.
A year later. That must make diagnosis incredibly difficult, especially for travelers.
It really does. Someone could travel, come home, feel fine for months, and then get sick. If they don't tell their doctor about travel from way back, or the doctor doesn't ask, malaria might not even be considered initially. It's why that travel history is so important if you develop a fever.
Definitely. And are there specific groups who are just more vulnerable, more likely to get sick or get sicker?
Yes, definitely. Infants and children under 5 are at very high risk. Pregnant women too, people living with HIV/AIDS, and then anyone with little or no built-up immunity that includes migrants moving between areas, mobile populations, and of course, travelers going into endemic regions for the first time.
And that long incubation, the relapse potential. It just adds another layer of complexity for travelers and migrants.
Exactly. Makes diagnosis tricky, makes prevention advice complicated too. Always comes back to needing that detailed travel history.
Okay, so someone comes in, they have a fever, maybe they've traveled. How do doctors confirm it is malaria? What's the diagnostic process?
Well, the absolute key is timely and accurate diagnosis. It's crucial for treating the person effectively, obviously preventing death, but also for stopping onward transmission in the community.
Right.
So while the symptoms and the history raise suspicion, you always need laboratory confirmation. And like we said, asking about travel in the last year is standard practice for anyone with a fever.
So what are the lab tests? What's the main method?
The traditional gold standard is still blood smear microscopy.
Okay, looking under a microscope.
Exactly. You take a drop of blood, make a thin smear and a thick smear on a glass slide, stain it with special dyes, and then a trained technician looks at it under a microscope.
What can they see?
They can actually see the malaria parasites inside the red blood cells. Microscopy is great because you can identify the specific Plasmodium species, which is important for treatment. You can see the different life stages, like gametocytes, and you can even count the parasites to get an idea of the parasite density, how heavy the insection is. That helps track if the treatment is working.
That sounds pretty definitive. Are there downsides to microscopy?
There are. It requires skill. You need well-trained microscopists, especially to spot parasites when there aren't many, or to tell the difference between species, or if someone has a mixed infection with 2 types.
Right, it's not automatic.
No. And its sensitivity can be lower if parasite levels are really low. Plus, maintaining high-quality microscopy services, keeping equipment working, keeping staff trained, that can be tough in remote, resource-poor areas.
Okay, that makes sense.
Yeah.
So what about the rapid tests? The RDTs, we hear a lot about those being used, especially out in the field.
Yes, rapid diagnostic tests, RDTs, are a really valuable tool, especially where good microscopy isn't easily available. They're basically like little plastic cassettes, immunochromatographic tests.
Like a pregnancy test kind of idea.
Sort of, yeah, in principle. They detect specific proteins, antigens that the malaria parasites produce. You just need a drop of blood, usually from a finger prick.
And they're rapid, hence the name.
Exactly. Results usually in maybe 2 to 15 minutes, sometimes up to 20. They're easy to use, don't need electricity or fancy equipment, so they're great for point-of-care testing, even in very remote places.
That sounds incredibly useful. Do they tell you the species?
Some are designed just to detect falciparum, the most dangerous one. Others can detect falciparum and/or other species like Vivax. But it's important to know they're generally less sensitive than good microscopy or PCR. They might miss low-level infections.
Okay.
So if someone has strong symptoms but the RDT is negative, especially in a high-risk area, you'd ideally want to confirm with microscopy if possible. And another point, RDTs that detect Vivax often don't perform quite as well as the falciparum ones, partly because Vivax parasite levels tend to be lower.
Right, nuances there. And what about PCR? Polymerase chain reaction, is that used for malaria diagnosis?
Yes, PCR testing exists for malaria. It detects the parasite's genetic material, its DNA or RNA in the blood. It's the most sensitive method we have, capable of detecting really, really low levels of parasites.
So why isn't it used all the time?
Well, it's most useful for confirming the species after you've already got a diagnosis from microscopy or an RDT, especially if you suspect a mixed infection or need precise species identification. It's also vital for research, like tracking drug resistance markers.
But not for the initial diagnosis, usually.
Not typically in a standard clinic setting, no. Because it takes longer to get results. It's not rapid.
Wow.
And it needs specialized lab equipment and trained staff. So for that first crucial diagnosis to start treatment quickly, microscopy and RDTs are still the mainstays. PCR is more for refinement, confirmation, and research.
Got it. PCR is super sensitive, but slower and needs a proper lab.
Exactly. Great for specific situations, but not usually for that frontline immediate diagnosis.
Okay, so diagnosis covered. Let's move to treatment. Once malaria is confirmed, how do we fight it?
The good news is malaria is treatable. With prompt, accurate diagnosis and the right treatment, we can definitely reduce illness, prevent deaths, and also help stop the spread.
Right.
And choosing the treatment is always based on evidence. What's safe, what's effective, considering the parasite species, how sick the person is, their age, any other health issues, and critically, local drug resistance patterns.
And for most cases, especially falciparum, it's ACTs, right? Artemisinin-based Combination Therapy.
That's correct. For uncomplicated malaria, particularly falciparum, ACTs are the recommended first-line treatment pretty much everywhere now.
And why combinations?
Because they combine 2 or more drugs that attack the parasite in different ways. This boosts effectiveness and, really importantly, helps slow down the development of drug resistance. If the parasite develops resistance to one drug, the other one hopefully still works.
Smart. What are some examples of ACTs?
Common ones you hear about are artemether-lumefantrine, artesunate-mefloquine, artesunate-amodiaquine, artesunate-sulfadoxine pyrimethamine, and dihydroartemisinin piperacillin, often called DHA plus PPQ. WHO strongly backs these for uncomplicated falciparum.
Are other older drugs still used at all? Like chloroquine?
Sometimes, yes, but it depends heavily on the situation. Other options include atovaquone-proguanil, quinine sulfate, usually given with another drug like doxycycline or clindamycin. Chloroquine, well, resistance is so widespread now, especially in falciparum, that its use is very limited.
But maybe for VVAX sometimes.
Exactly. In places where PVVAX is still sensitive to chloroquine, it's often used, but importantly, it must be combined with primaquine to kill those liver hypnozoites and prevent relapse. If the Vivax is resistant to chloroquine, then ACTs are generally recommended for the blood stage part.
Okay. Now, what about severe malaria? You said it's a medical emergency. How is that treated differently?
Yeah, severe malaria needs immediate aggressive treatment in a hospital setting. The key is starting parenteral antimalarials right away. That means giving the drugs intravenously, IV, or intramuscularly, IM.
What? 5E or IM?
To get the drug into the system fast and reliably, bypassing any issues with absorption from the gut if the person is very sick, perhaps vomiting or unconscious.
Makes sense. What drug is preferred?
The top recommendation now for severe malaria in both adults and children is IV or IM artesunate. It's been shown to be superior to the older option, quinine. Quinine is still an acceptable alternative if artesunate isn't available, though.
And how long is this intensive treatment needed?
Usually the parenteral treatment continues for at least 24 hours, or until the patient can safely take oral medication. Then they need to complete a full course of an oral ACT, or maybe artesunate plus clindamycin or doxycycline or quinine plus one of those to fully clear the infection.
So the goal is just survival initially?
Primarily, yes. Prevent death. Secondary goals are to prevent long-term disability, like neurological problems after cerebral malaria, and prevent the infection coming back.
Are there special treatment rules for vulnerable groups, like pregnant women?
Yes, absolutely critical considerations there. For pregnant women, it depends on the trimester. First trimester, quinine plus clindamycin is often preferred. ACTs might be used if that's the only option or if quinine fails.
And later in pregnancy?
Second and third trimesters, effective ACTs are generally considered safe and effective, or the artesunate plus clindamycin options. Interestingly, mefloquine can be used for prevention throughout pregnancy in some guidelines, but drugs like doxycycline and primaquine should definitely be avoided during pregnancy.
What about tiny babies or people with HIV?
For infants, especially those under 5 kilos, there's specific guidance on ACT choice, and getting the dose right based on weight is crucial. For patients with HIV/AIDS, the main concern is potential drug interactions between certain ACTs and some antiretroviral drugs, like avoiding specific combinations with cotrimoxazole or efavirenz.
Wow, okay, so treatment is definitely not one size fits all. Lots to consider.
Not at all. It requires careful assessment. The patient, the parasite, the severity, other conditions, local resistance patterns. It really highlights the need for up-to-date guidelines and well-trained health workers.
Okay, let's shift now to maybe the most important part, prevention and control. How do we stop people getting malaria in the first place?
Well, the basics are pretty straightforward. Avoid getting bitten by mosquitoes and use preventive medication when appropriate. WHO really emphasizes effective vector control for everyone at risk.
And the big one for vector control is insecticide-treated nets, ITNs. How well do they actually work?
They've been incredibly successful. ITNs have been a cornerstone for, over 2 decades now? They've massively reduced child deaths, overall parasite rates, and both simple and severe malaria cases.
Really? That's significant.
Oh, yeah. Widespread ITN use is credited as a major factor in the big drop in malaria cases and deaths we saw globally from the early 2000s onwards. A huge public health success story.
I hear about mosquitoes getting resistant to the insecticides on the nets. Is that undermining their effectiveness?
That is a major concern, yes. Insecticide resistance, especially to pyrethroids, the main insecticide class used on standard nets, is widespread now in many malaria areas. And yes, it can definitely reduce how well the nets work.
So what's being done about that?
There's been a big push to develop and roll out next-generation nets. These often have 2 different insecticides combined, maybe a pyrethroid plus something like chlorfenapyr or pyroproxyfen.
Dual insecticide nets.
Exactly. WHO recommended these newer types in 2023. Studies show they provide significantly better control, maybe 20 to 50% better than standard nets, especially where pyrethroid resistance is high. It's an ongoing battle, adapting the tools.
So innovation is key. What else can people do personally to avoid bites? Repellents.
Yes, insect repellents are important. Look for EPA-registered ones with active ingredients like DP, TEEP, keratin, IR3535, oil of lemon eucalyptus, OLE, or PMD. Using repellent, especially during peak biting times, adds another layer of protection, ideally used with other measures like nets.
What about getting rid of mosquito breeding sites? Does that help? Cleaning up standing water?
Environmental management is definitely part of the picture. Reducing places where mosquitoes can lay eggs makes a difference. Simple things: emptying containers, holding water around the house, old tires, pots, buckets, clearing drains, changing water in bird baths frequently, filling in puddles near homes where possible.
And screens on windows.
Absolutely. Good screening on windows and doors, keeping them closed, especially evenings and mornings, repairing any holes. Sleeping in a well-screened or air-conditioned room, if possible. All these physical barriers help.
Okay. And then there's take medication before you even get bitten, right? Chemoprophylaxis for travelers.
Yes, chemoprophylaxis. Taking anti-malarial drugs preventatively. It's highly recommended for most people traveling to areas where malaria is a risk.
How do those drugs work?
They basically work by suppressing the parasite stage in the blood. So if you do get bitten by an infected mosquito and parasites get into your blood, the drug stops them multiplying and causing illness.
What are the common options for travelers?
Common ones are atovaquone progranol, which you might know as Malarone, doxycycline is another, and mefloquine. The best choice depends on where you're going, for how long, your health history, other meds you take, potential side effects, cost, lots of factors.
And you have to take them correctly, right? Before, during, and after the trip.
Absolutely essential. You need to start before you enter the risk area, take it regularly throughout your stay, and continue taking it for a specific period after you leave. Adherence is key for it to be effective.
So it sounds like the best prevention is really a combination of things: nets, repellents, clearing water, maybe medication for travelers.
Exactly. It's a multi-pronged approach. Community-level vector control like ITNs, combined with personal protection measures and targeted chemoprophylaxis where needed. That gives you the best chance of staying malaria-free.
Well, this has been incredibly thorough, a real deep dive into malaria. If we had to sum it all up, what are the absolute key takeaways for listeners?
I think the main things are malaria is still a massive global health problem, even with all the progress we've made.
Right.
Its persistence is down to this complex mix, the history, the tricky biology of the parasite and mosquito, and these deep-rooted socioeconomic factors that affect who gets exposed and who gets care.
And tackling it effectively needs a sustained, comprehensive effort. It's not just one thing.
Absolutely not. It needs everything working together. Effective vector control, rapid and accurate diagnosis for everyone, the right treatment strategies, including dealing with drug resistance and special groups, plus all those preventive measures at the personal and community level.
It really is sobering, though.
Yeah.
We know so much. We have tools that work, yet hundreds of thousands of people, mostly young children in Africa, are still dying from this preventable, treatable disease every year.
It really does lead you to a fundamental question, doesn't it? Given everything we know scientifically, given the tools we have, why does malaria continue to cause such devastation? What really needs to change in terms of global priorities, funding, political commitment to genuinely, finally turn the tide and make malaria history?
That's a powerful question to leave people with.
Yeah.
Really makes you think about a bigger picture, the inequities. Thank you so much for walking us through all of this. It's been incredibly insightful.
My pleasure. It's a critical topic.